In public health, secondary prevention aims to detect disease in its earliest stages, often when it is still without symptoms, and offer an appropriate intervention to slow or prevent progression of the disease. Screening is a case-finding public health service offered to people in a defined population, for example people with diabetes, who may or may not perceive they are at risk of a disease or its complications. They are offered a simple and acceptable test which identifies those individuals who are likely to benefit from further tests and/or treatment to reduce the risk of irreversible complications, such as blindness. A case here is referred to as a person with the condition. Not all diseases or their complications are suitable for screening. 40 years ago, Wilson and Junger set out a list of 10 criteria that need to be met in order to implement a public health screening programme. First, the condition or disease must be a public health problem affecting a defined population. Second, there should be a recognisable latent or early symptomatic stage. Third, the natural progression of the condition from latent to declared disease must be adequately understood. Fourth, there should be a suitable test or examination to identify the condition. Fifth, the suitable test should be acceptable to the population. Sixth, facilities for diagnosis and treatment should be available. Seventh, there should be an accepted treatment for patients with recognised disease. Eighth, there should be an agreed policy on whom to treat as patients. Ninth, the cost of case finding should be economical. And 10th, case finding should be a continuous process for chronic conditions, and not a once and for all project. If we examine diabetic retinopathy against Wilson and Junger's criteria, we can see that epidemiological studies have shown that diabetic retinopathy is a public health problem, with a rising prevalence due to the increasing number of people with diabetes. The natural course of diabetic retinopathy progression is well understood. It has a clear, latent early stage that can be adequately identified on examination and classified into background and even pre-proliferative retinal changes. So diabetic retinopathy meets Wilson and Junger's second and third criteria for screening. We are able to detect its early signs and intervene with treatment to prevent visual impairment and blindness from the disease. The screening test for diabetic retinopathy is carried out by trained personnel who examine a person's retina using a suitable method. The retinal fundus examination is generally simple, non-invasive and acceptable. However, the most appropriate examination method has to be determined locally, as it is based on available resources, human, infrastructure and financial, for screening and treatment within the health system. Once a person with diabetes has a positive referral outcome, a case, they must be referred in a timely manner for further examination, diagnosis and treatment using an established referral protocol. Wilson and Junger's 6th, 7th and 8th criteria address this by requiring that policies, facilities and trained personnel for the diagnosis and acceptable treatment of diabetic retinopathy are available. A public health screening service for diabetic retinopathy needs to invest in appropriate laser facilities as a minimum requirement and in the capacity to provide or refer for vitreoretinal treatment. These facilities and their trained personnel should ideally be established prior to the rollout of a diabetic retinopathy screening programme. Many eye health settings face challenges in meeting these criteria due to shortages in facilities, trained personnel and equipment. Criteria 9 addresses the key issue of the cost of screening, which has to be both acceptable to the patient and sustainable within the health system. Some health systems may provide diabetic healthcare schemes or insurance towards direct screening costs. However, there may also be a range of indirect costs to patients to attend screening, which become additional barriers for acceptance and uptake. Wilson and Junger's 10th criteria for diabetic retinopathy screening programs is that case finding has to be an ongoing process throughout the life of each person with diabetes. In the UK, after a lot of coordinated efforts, the annual coverage for diabetic retinopathy screening is above 80%. However, many places face multiple geographical, economical and social challenges to achieving good coverage in diabetic retinopathy screening. For example, women may not be able to attend screening on their own. In these settings, it may be best to put opportunistic screening in place, at least initially, until a clear pathway for systematic screening can be found. In summary, The Wilson and Junger criteria for screening are, in principle, fully applicable to diabetic retinopathy. However, the local conditions affecting a health system in terms of healthcare facilities, equipment and personnel will determine whether a systematic diabetic retinopathy screening programme can be rolled out. Once a diabetic retinopathy screening programme is in place, individual patient acceptance and adherence to screening is key to achieving high coverage.